Uno, good afternoon. Thanks again for joining. My name is Jose Scher. You probably know me from previous talks or other meetings, and I will be talking about advances in rheumatoid arthritis as it pertains to this year 2020. And here are my disclosures, of course. So here's the outline. I'm going to talk briefly about preclinical rheumatoid arthritis, followed by new concepts in RA pathogenesis and the power of high throughput sequencing, and then devote some of the time to understand the saga of JAK inhibition in rheumatoid arthritis, which are a very effective class, but with some safety considerations, and I'll keep you up to date on what's known. In terms of preclinical rheumatoid and the role of glycosylation in potential biomarking for preventive clinical trials. What we know so far, and we've heard this before, is this idea that rheumatoid arthritis is a complex polygenic multifactorial disease. It affects women more so than men. And it starts at a healthy state in which genetic factors predispose people to the development, HLA, DRB1, share epitope, and other SNPs, that in the presence of environmental exposure, such as smoking, hormones, diet of bacteria, can trigger the initial phase of what we now call preclinical rheumatoid arthritis, where there's a loss of tolerance and a phase of autoimmunity, demarcated by an increase in the levels of autoantibodies as well as pro-inflammatory cytokines. This is followed by an epitope spreading and a tighter elevation of these cytokines and autoantibodies in an early synovitis phase, or the transition phase, in which potentially a second hit is implicated in the transition to what we now know or classify as clinically evident rheumatoid arthritis. So large prospective observational studies of RA onset, such as those emanating from the Nurses' Health studies and from Olmsted County, have shown age-adjusted incidence rates of about 26 to 40 cases per 100,000 person years. A study of combined data from Swedish patient registry demonstrated roughly 4 times increase of risk of development of rheumatoid arthritis in first-degree relatives of patients with autoantibody-positive rheumatoid. And a prospective cohort study from the Netherlands recruited individuals based on ACPA or rheumatoid factor positivity, and the presence of arthralgia demonstrated an inflammatory arthritis incidence rate of about 20% after a median of about 1 year. More recently, however, the group in Manitoba showed that despite a high incidence of inflammatory arthritis in a cohort of at-risk relatives of indigenous North Americans with rheumatoid arthritis, a large proportion of autoantibody-positive individuals did not develop inflammatory arthritis and may revert back to an autoantibody-negative state. So what about those ACPAs? And is there any new data showing that there are specific properties of glycosylation that may precede the development of rheumatoid arthritis? So we know that IgG anti-citrulline protein antibodies are abundantly N-glycosylated within their variable domains, or the V domains. And although it is known that N-glycosylation sites are introduced following somatic hypermutation, 2 questions are yet to be answered. Number 1, which factors are actually those that trigger the generation of V domain glycans? And number 2, are these glycans relevant for rheumatoid arthritis transition? To answer this, the Dutch group analyzed ACPA IgG V-domain glycosylation using ultra-high performance liquid chromatography in paired samples of both pre-symptomatic individuals and rheumatoid arthritis patients. And as you can see on the graph, liquid chromatography peaks, ACPA IgG V-domain glycans were detected in both ACPA positive and pre-symptomatic individuals with RA patients. So result number 1, ACPA domain glycans are present in both cohorts. To address the question of when V-domain glycosylation first appears, much pair individuals were sampled before symptom onset, between about 15 and half a year before, as well as after the diagnosis of rheumatoid arthritis, and then analyzed for the presence of ACPA V-domain glycosylation. In panel A of these figures, you can see that V-domain glycosylation was already present in pre-symptomatic individuals. And in panel B, analysis of 29 matched pairs with detectable V-domain glycan peaks showed a statistical significant increase in ACPA glycosylation towards disease onset. And finally, a logistic regression analysis using detectable ACPA IgG V-domain glycans as outcomes showed an association between these antibodies and HLA shared epitope. And taken together, this data suggests that V-domain glycosylation precedes the development of ACPA-positive rheumatoid arthritis and may help improve current predictive algorithms, allowing for the early treatment in high-risk individuals. A similar and validating study was performed in first-degree relatives of rheumatoid patients from Manitoba. They analyzed 2 independent sets of serum samples obtained from 126 ACPA-positive first-degree relatives of rheumatoid patients. Both sets originated from an indigenous North American population and comprised cross-sectional and longitudinal samples of individuals who did or did not develop inflammatory arthritis. Here again, serum IgG ACPAs were affinity purified and subjected to liquid chromatography based glycan analysis. In terms of results, you see in panel A that first-degree relatives derived IgG ACPA displayed markedly lower levels of V-domain glycans. This is below 50% compared to IgG ACPA from rheumatoid patients. Notably, panel B shows that first-degree relatives who later developed RA showed extensive V-domain glycosylation before the onset of arthritis. Moreover, IgG ACPA glycosylation was strongly associated with future development of rheumatoid arthritis, again, validating that this N-glycosylation process is a strong predictive biomarker for the development of rheumatoid arthritis development, and may be used for stratifying high-risk individual for intervention studies. Now, multiple studies conducted about a decade ago in the preclinical phases of rheumatoid arthritis showed modest effects in this preclinical phase using either systemic steroids, methotrexate for about a year, or even abatacept for 6 months. So these were the therapeutic strategies in preclinical rheumatoid arthritis that happened over the last 10 years or so. And so the most recent study, however, which is now termed PRAIRIE, explored the effects of B-cell directed therapy in subjects at risk for the development of RA. This was a randomized double-blind placebo-controlled study in individuals with positive, that were positive for both ACPA and rheumatoid factor antibodies, but without the presence of arthritis, to receive a single infusion of 1 gram of rituximab versus placebo. 81 individuals received treatment and were followed up for a mean of 29 months, during which about 37% of individuals actually developed arthritis. The observed risk of developing arthritis in the placebo-treated group was about 40%, which was decreased by 55% in the rituximab-treated group at month 12. Furthermore, and as you can see in the Kaplan-Meier curve, rituximab treatment caused a delay in arthritis development of about 12 months compared with placebo treatment at the point when 25% of subjects had developed arthritis, suggesting that a single infusion of rituximab can significantly delay the development of arthritis in subjects at risk for the development of rheumatoid arthritis, providing evidence for the pathogenic role of B cells in the earliest pre-arthritis stage of autoantibody positive rheumatoid arthritis. Now, beyond PRAIRIE, which is the only one published study so far, several other studies are currently underway that aim at the prevention of rheumatoid arthritis development, stop array being one of the most relevant ones in terms of utilizing hydroxychloroquine, but others are also on their way. And importantly, the inclusion criteria as well as the treatment strategies vary significantly. So we won't be able to compare apples to apples necessarily, but we will be able to learn in terms of pathogenesis of disease. Now, what are the newer concepts in rheumatoid arthritis pathogenesis, and what is it that we've learned from high throughput sequencing approaches? To define the cell populations that drive joint inflammation in rheumatoid arthritis, the group from the Accelerating Medicine Partnership has applied single-cell RNA sequencing, mass cytometry, bulk RNA-seq, and flow cytometry to T cells, B cells, monocytes, and fibroblasts from over 50 samples of synovial tissue derived from patients with either rheumatoid arthritis or osteoarthritis. They then utilized an integrated strategy based on canonical correlation analysis of about 5,000 or more single-cell RNA-seq profiles, ultimately identifying 18 unique cell populations that we're not aware of before. Combining mass cytometry and transcriptomics, there were several cells expanded in rheumatoid arthritis synovia. This included type 1 HLA-DRA high sublining fibroblasts, ILB positive pro-inflammatory monocytes, autoimmune-associated B cells, and these new peripheral T helper cells, which had similarities with follicular helper T cells. A distinct subset of CD8 cells were characterized by the presence of granzyme K, granzyme B, and others molecular markers, which offer a new phenotype of these CD8 cells. And finally, they were able to link inflammatory cytokines to their source of cell populations. For example, interleukin-6 expression was linked back to Thy1 HLA-DRA fibroblasts, and ILB, for example, its production was linked back to pro-inflammatory monocytes. Taken together, these new technologies are leading to the discovery of new immune and effector cell populations, which are potentially key mediators and also targets of RA pathogenesis. And then really amazing work recently published in the New England Journal by Dana Orange and colleagues. The group established a very clever clinical and technical protocol for repeated home collection of blood in patients with rheumatoid arthritis to allow for longitudinal RNA-seq capture of the cell population. Specimens were obtained from over 350 time points during 8 flares over a period of 4 years in their one index patient, as well as from 235 time points during flares in 3 additional patients. Transcripts differentially expressed before flares were identified and compared with data from synovial single-cell RNA-seq. And finally, flow cytometry and sorted blood cell RNA-seq in 19 additional patients were used to validate the findings. You can see here the repeated home collection of blood in rheumatoid patients with RNA longitudinal capturing, and the study design as well. Using this protocol, they found consistent changes in blood transcriptional profiles 1 to 2 weeks before a rheumatoid flare. You can see in panel A on the left-hand side that cluster 1 represented a group of genes that had increased expression, here in red, after symptom onset. However, there are 2 antecedent clusters, or AC, that were upregulated before flares, AC2, about 2 weeks prior, and AC3, which was present about 1 week pre-flare. In panel B, on the right-hand side, you can now see that AC2 was mostly enriched with naive B cell genes, while AC3 was dominated by a population of CD45 negative, CD31 negative, PDPN positive pre-inflammatory mesenchymal cells, or the so-called prime cells. Intriguingly, these prime cells share many features of inflammatory synovial fibroblasts. And notably, levels of circulating prime cells decreased during flares in all 4 patients. This data was validated with flow cytometry and sorted cell RNA-seq, which confirmed the presence of prime cells in 19 additional patients with rheumatoid arthritis. So here is the model of blood and synovial gene expression changes before and during rheumatoid arthritis flares. Unknown inflammatory signals activate naive B cells here at baseline, and now also turn AC2, which in turn activate prime cells. Again, these so-called AC3 clusters. These cells harbor the signature for synovial sublining fibroblast genes. And according to these models, this model, prime cell demarginate and are increased in the blood before a flare, and then decrease just after symptom onset. These cells are increased in inflammatory synovium in patients with rheumatoid arthritis, where they most likely contribute to and may be sufficient to cause joint inflammation. Now, to finalize, this is what I call the JAK inhibition saga in rheumatoid arthritis. Very effective class with some safety considerations. I'll walk you through some of the most recent primary data. I will share a few phase 3 studies in various JAKs with very similar design. The first one is RA-BEAM, which is looking at baricitinib versus adalimumab versus placebo in moderate to severe rheumatoid arthritis patients who were methotrexate inadequate responders. At week 12, both primary endpoints were met in patients receiving the drug, which again consisted of ACR 20. And then the secondary endpoint included ACR 20 at week 12 versus adalimumab. And the results you can see here that ACR 20 improvement was significant for the Bari arm versus 40% in the placebo group. And there were all of the secondary endpoints met, including the inhibition of radiographic progression, which was higher in baricitinib versus placebo. There were safety signals, including adverse events, which were higher in the Bari and the adalimumab group compared to placebo. Serious infections were again noted in Bari and adalimumab at about 2%, including herpes zoster. Platelet counts had a modest increase in the Bari group, and there were a few deaths, one in the placebo arm, one in the adalimumab group, and 2 in the Bari group, with 1 on the placebo into Bari crossover. Now, this was met with some concerns at the FDA meeting a few years back, in which efficacy considerations were put forward. Both doses, 2 milligrams and 4 milligrams, were effective, but they couldn't really find a data showing meaningful benefit of 4 milligrams over the 2 milligram dose. And the radiographic response, however, was more robust in the higher dose. However, their safety considerations were relevant, including the serious infections with zoster and opportunistic infections, but presumably most relevant was the issue of both venous and arterial thrombosis, which has led to the comment that there were at least a major concern with at least 7 venous thromboembolic events in the Bari arms across the entire randomized control trial program, which was not found in the placebo group, leading to the warning box in the label for Bari. A very recent paper looking at DVT-PE for both Bari and tofacitinib worldwide, using individual case safety reports, that is the VG base from the WHO global database, in which the primary outcomes were DVT and PE, estimating the reporting odds ratios and the confidence interval showed that in over 40,000 patients, there was an increased risk for DVT, or odds ratio for DVT, of about 2.3. for tofacitinib and an increased reporting odds ratio for DVT and PE of 3 to 4 fold for baricitinib, suggesting that an increased risk in post-marketing databases supports the current recommendation for cautious use of tofa and bari in patients with high-risk VTE risk, and a potential class effect of JAK inhibition cannot be ruled out based on this data. Select Compare was very similar. It's a phase 3 double-blind randomized control trial using upadacitinib, which is a selective JAK1 inhibitor compared to adalimumab and placebo in patients with methotrexate inadequate response. The primary endpoint including improvement in ACR20 and DAS28-CRP at week 12 versus placebo. And yet again, at week 12, both primary endpoints were met in patients receiving UPA compared to those receiving placebo. In terms of safety profile, adverse events were higher in UPA and adalimumab compared to placebo, with slightly higher serious infections in the UPA group and somehow expected increase in herpes zoster in that same group. In terms of VTE, the adalimumab group had close to 1% incidence versus 0.3% in the UPA group, which has led to the approval ultimately of this particular JAK. Finch one, last one. It was looking at filgotinib, 100, 200 milligrams versus adalimumab versus placebo, very similar study design in methotrexate inadequate responders. This is yet again a selective JAK1 inhibitor of used in rheumatoid patients, a phase 3. Both doses with the primary endpoint again being ACR20 at week 12. And what we see is that the drug has achieved the primary endpoint with both doses, but when it came to looking at non-inferiority or superiority test of filgotinib versus adalimumab, only the filgotinib at higher dose achieved its outcomes. The safety profile here, as you can see, was a low incidence of VTE and herpes zoster. However, about a week or so ago, the FDA has issued a complete response letter regarding the NDA for filgotinib. Here, the FDA expressed concerns of testicular toxicity, which was previously associated with high doses of filgotinib in preclinical models of arthritis, particularly in rats and dogs. And the sponsor is currently conducting safety trial examining male reproductive safety of filgotinib in men with IBD and men with active inflammatory arthritis in the MANTA and MANTA-RAY study, safety studies. So with that, I'd like to finish by telling you that JAK inhibition has consistently shown robust efficacy in rheumatoid arthritis trials, mostly in a dose-dependent manner, and that irrespective of selectivity, JAK inhibition have demonstrated non-inferiority, at least to TNF drugs, although thromboembolic events appear to be related to JAK selectivity. Regulatory agencies have included warnings for all drugs in the class, and other adverse events of interest may help understand the JAK-STAT distinctive pathways and its implications in clinical benefit risk for rheumatoid and related conditions. So with that, I will stop, and I thank you so much for your attention and hope you're having a good pulmonary